Okay. So picking up on yesterday was more just terms, roles, but when I talk about in my little 3-step plan, know your patient, know your drugs, pay attention. That's what we're building this first term in anesthesia. So this is kind of the know your patient part. And the more you know about your patient, the better prepared you're going to be. Like I said, if a dog walks in the door and it's a bulldog, to me, there's no such thing as a healthy bulldog. I mean, that's kind of a joke. A 6-month-old bulldog walks in the door for a spay. It can be, as healthy as the owner thinks, but the breed itself presents challenges to the procedure. So my brain already starts working through problems like, how am I going to do this anesthesia? What do I have to prepare? So, obviously when you start talking to the owner and you get your database, there's more to it, but that's what we're starting to build is how do we get ready with the patient? And as an anesthetist or even as an employee, there is always going to be a minimum database, which is what information do we need to know to complete the procedure. One of the things in that database is going to be blood work. Now, when you guys are in surgery rotation, they have different panels. I don't know if you remember from blood chemistries, there's sometimes a short panel that does like a glucose, a BUN, a liver test, the ALT, a liver test. And then there's what we call a complete profile, which gives us some more values. Your clinic will go over what minimal blood work the doctor requires. Now, the sticky situation is you're always going to have clients that are going to nickel and dime you or say, I don't want to have the blood work. Or I had a client, she had refused heartworm tests every year. Okay, this was a golden. And every time she refused the test, we put it in the chart and the owner had to sign that she refused the test. This dog comes in probably 10 years old, has a massive lipoma. She wants a dental and she wants the lipoma removed. And the doctor was like, I'm not doing this surgery without getting a heartworm test. Turns out the dog was raging heartworm positive. And she started to bitch a fit and say, oh, I've never been told about heartworm, blah, blah, blah. We pulled out her chart and showed her every time in the chart that it was recommended to have a heartworm test, and every time she declined. Now, the doctor can say, I inform you of the risk, and they can sign off responsibility. The doctor can refuse to do the procedure. If the doctor says, this is my minimum requirement, if I'm going to operate on your animal, if you don't like it, you can go somewhere else. So the database will be provided by the clinic, but there's a good reason. And sometimes it's the job as the technician when you go in the room and you give an estimate and they go, why are you doing this, this, and this? And you have to be able to explain, we need to know if your dog's heartworm negative. We need to know why we check the liver. And we're going to get into fasting. The first thing you have to find out, did they eat last night? Because, anesthesia can make them nauseous. We don't want them vomiting and aspirating food. So that is why we usually say no food or water the night before. Obviously, you have to make sure anything we have to do pre-induction, any blood work, fluids, any preventative care, check your equipment, draw up your pre-anesthetics. That's kind of all your role in the patient prep. And when it starts is your communication to the client. Again, you want to ease their mind. You want to explain the procedure that's going to happen, how long. And the more you communicate with the owner, the better it should go. Now, in your book, these little slides come from your book. There are these little charts, these little kind of checklists. Now, usually you'll have some type of a routine. You take in the client and you have a list of questions that you go through. But typically, one of the first things is we have to obtain consent. So usually there is some form that requires a signature. Now at VCA, the specialty hospital, our financial estimates were linked with client consent. So they would look at the bill, what the expected bill is, and then at the bottom it would say, I understand and I consent to the procedure. So sometimes the financial estimate and consent are tied into the same form. And usually they need you, a good clinic should have some type of fee estimate given to the client. We didn't always require a deposit before. Usually it was just pay when you pick up. Some clinics might say, if it was a major procedure at VCA, sometimes it required the owner to put down 50% of the surgery and pay the remainder at pickup. So there's sometimes deposits taken, sometimes not. But a good financial estimate needs to be given to the client. And I will tell you, at VCA, we always had like a miscellaneous category. And sometimes like oncology patients, I'd put like $200 on there. And I explained to the client, this might be extra medicine we want to go home, or during a procedure, something might happen and we have to, add more medications. And we can't always predict. Now, if they're coming in for a spay or a neuter, you pretty much know what you're going to do. Sometimes the procedure is more complex, but you want to have all of that. Time for pickup, that has to be communicated. The big thing on the bottom there that I like to stress is an emergency communication protocol. Sometimes the owners, and specialty is a little bit different than your regular clinic. Sometimes the owner fills out a paper and they don't have great handwriting, and you look at this phone number. I always read the phone number back to the client. I said, do you want to be reached at 317-849-0140? And they're like, yes. Because in an emergency, you don't want to be looking at that number and it's the wrong phone number. The other thing for my radiation patients is I always said, can I call you? Are you reachable during the day? Did you prefer a text? Our clinic did give text updates to clients. And that also, if they would accept a text, sometimes that was a quick way to say, hey, Fluffy's done. You can pick up in an hour. So a lot of clinics are now linking to smartphones and can send pictures, but you always need to know in an emergency, how do we get a hold of them? And what are their wishes? Part of the minimum patient database, and this is what it concludes. It has a history, the physical exam and the assessment, and then the diagnostic workup. Now, the diagnostic workup is the lab work that we're going to do. That will be determined, again, by the doctor, the type of, if it's a 12-year-old poodle for a dental, there's going to be a lot more blood work probably than it's a 6-month-old for a spay. So there's usually a geriatric protocol. There's usually a pediatric or adult protocol. And then we go from there. But normally the technician is the one who goes in and gets the history. And so this is kind of a list of everything you need to go through. Obviously confirming why they're there. So, Fluffy's here to be spayed today, correct? And then you start to get, how has Fluffy been feeling? Has Fluffy had any issues in the past? Good activity? Anything out of the normal? Did Fluffy eat anything last night? Fasting instructions, I will tell you, there's a lot of differing opinions. It used to be, we don't want the animal to have anything after dinner or after midnight. No food or water after midnight. Now, geriatrics sometimes are on the border of renal failure, and their access to water is the only thing keeping their kidneys going. So normally, and in oncology, I was usually dealing with older patients. So I said they couldn't have any food after midnight, but I said leave their water down. That's a doctor preference, but I will tell you, our geriatric patients, especially old cats, if you take up their water, say like after dinner, they might go a full 12, 14 or so hours without water. And that could cause some issues if they were borderline, and again, a geriatric is not a disease. Being old is not a disease, but as organs age, they start to creep into potentially having problems. So I would always say, and in exotics, we don't fast. We don't typically fast exotics because they have such a high metabolism. If you take away food from a rabbit, that'll affect their GI tract. Mice and rats, definitely with that higher metabolism. So I'm not sure if Niemer got into some of that in Animal Tech 5, because normally we've moved anesthesia. So normally I've done exotic anesthesia with you by the time you have Tech 5. So it's a little bit different this term. But exotics are going to have a completely different fasting protocol. Pediatrics, you have a tiny little puppy, like a Chihuahua, they can become very hypoglycemic if they don't have access to food. So my big thing is you have to find out if they fasted, but fasting instructions can vary from doctor preference to the type of patient. You need to make sure there's any current vaccines. The big thing is heartworm status. And like I just told you, if we would have anesthetized that dog that was raging heartworm positive, there's a good chance when you anesthetize a dog that has heartworms, when you give anesthesia to the dog, the worms can become sedated or anesthetized. Actually, the worms can dislodge. And then what it does is it becomes a floating clot of worms. It can become an embolism. So I have done anesthesia on dogs that are heartworm positive if we've absolutely have to do it, but you have to watch them very closely. So definitely knowing heartworm status is key. And my doctor told that lady, he's like, I'll forego some of the other tests. He goes, but I won't do this procedure without a heartworm test. And it's a good thing we did, because then we were doing heartworm treatment, not removing a lipoma and doing a dental. And then if there's any pertinent condition issues, problems, normally what I would do is then I'd bring the dog back and I would talk to the veterinarian, and then the veterinarian is going to do their physical. But I start with the history, the physical, and go over all of the instructions. Now, I think you guys have talked about this probably in maybe Tech 1 or taking a history from a client. You want to try to avoid getting into leading them on, like, for example, if I said to you, your dog doesn't drink a lot of water, does it? The client's going to say no. But that doesn't give me an answer. If I say, how much water does your dog drink? It forces them to answer it in a way with more explanations. Or, your dog isn't tired all the time, is it? No. If I say, how is your dog's activity level? Does your dog exercise on a regular basis, and how much? So learning, I will say history taking is an art. And I would say when I was starting out, I would go in the room and ask questions, and I would be like, good. And I'd go back and sit down with the doctor, and he would be like, did you ask this? Did you ask this? Did you ask this? And then I'd be like, oh, shoot, I didn't ask that. Oops, I forgot. And then I would build, and then the next time I would remember to ask that question. So, and you want to make sure, again, you don't want to lead them into an answer. You don't want a yes or a no. You want a description. So the other thing is trying to get these answers. Making sure you're not forcing them to say something. They have to be able to give it to you freely. If they say, well, he's had diarrhea. Well, how long has he had diarrhea? What's the duration of, if he had diarrhea one time or he's had diarrhea for 2 weeks, very different scenarios. What is the volume when he vomits? How much does he vomit? Oh, does he spit up a little spot, or does he vomit a very large amount? And then, getting into the appearance. If he has diarrhea, this is when diarrhea. My husband even did this the other night. He's like, Bo had diarrhea. And I was like, he has diarrhea? And he goes, well, yeah, it was soft. And I go, well, like soft serve like ice cream, or was it like liquid? And he goes, oh no, just a little soft. And I'm like, okay, well, you come in telling me diarrhea, and then asking you questions, I got to what it actually looked like. And it turns out it was just a little soft, and what the next day was completely normal. So, or how often are they doing it? Coughing. This is a perfect one, because when we worry about heart disease or respiratory disease and someone tells me they're coughing, I said, when do they cough? I said, is it when they wake up? Is it in the middle of the night? Is it after they go for a walk? And the big thing is, like, does the coughing interrupt eating? Because an occasional cough when they wake up, maybe not a big deal, but if they go running and they're coughing, or they're trying to eat a meal and they can't even finish the meal without coughing, that's a more severe condition. Timing is a big deal when we get into dogs with heart disease, because again, mild heart disease doesn't interfere with activities like walking, exercising, and eating. But if you're having dogs that are having issues when they're walking, exercising, and eating, then that is something that's interfering with normal activity. We need to fix that or do something about it. So there are several notes under this slide that kind of get into how do you ask these questions? What does it look like? How long this has been going on. There's a note here about vomiting or urinating frequently, and it may not be as often. The owner may think it's all the time, but it doesn't interfere, or it isn't causing as much of a problem as maybe they think it's doing. And when you go in, obviously confirming, we don't want to make any mistakes in surgery. Obviously, if you anesthetize the wrong patient or did a procedure to that patient, that, this is very rare, but I went down to get a beagle out of intensive care once, and literally there were two beagles next to each other in the cages that almost looked identical. I was like, how ironic. So I had to look, but at VCA, we always take off their collars before we put them in a cage. It's just our policy, so that their collar doesn't get stuck on something and they can choke themselves. So no dog was allowed to be in a cage or a run at ICU at VCA with their collar. When we took them into the hospital, we would take off their collar, put it in a little cubby with their name, and then we would put an ID band, like a paper sticky, we would write with a Sharpie the client number and the dog name and put it around their neck. So every animal in the hospital was labeled. And on the cage, they had to have a cage card that had the client sticker. So we try to do everything we can to label any belongings, to label the collars, and then label the animal properly. And you want to make sure we get everything done that the client wants. A common thing that happens is a dog comes in for a dental, and then they're like, can we get his vaccines, and can you clean his ears, and also he has 2 little bumps on his back, can you take those off? Well, you don't want to forget to do any of that. You want to make a little list on the chart so that we make sure we get all of that done. So you confirm why they're there, label them well, make sure we're performing everything that they want. And when you talk to the client, you need to know where everything is. In oncology, sometimes we saw dogs that had multiple masses, but maybe we were only dealing with a mass that was causing a problem. Sometimes Cocker Spaniels are famous for getting these little sebaceous cysts. They get these little warts over their back. My friend's dog had that, but 2 on the back were always big and would get infected. He had little ones. She got upset because she took the dog to a clinic for a dental. She said, remove the 2 on the back that were really kind of gross. When she picked up the dog, the bill was $400 more than she was told, and every wart on the back was removed. Every sebaceous cyst, I should say. And they didn't call, they didn't confirm that was it okay to remove the other masses. So I don't know if it was the person that took the dog in that said she wants them all removed, but she refused to pay the extra $400. And she was right. I mean, that clinic should technically eat that cost because what she signed was different. Now, what the clinic could have done, sometimes during a procedure, the doctor will call the owner and say, hey, we've got your dog asleep right now. I can remove these other masses. Are you okay with that? It'll cost another blah, blah, blah. And then the owner can say, okay. But you know, you really just don't want to surprise clients because then you get yourself in a mess. So which masses, where are they located? A lot of times when we remove masses from dogs, does the owner want to send them off to the lab for cytology or histology? Which if we do histopathology, we send it to the lab and the doctor's gonna look at it and decide, is it benign, is it cancerous? But you want to try to get all those wishes down, especially where tumors are located. Because, you know, if the dog has one giant tumor, not a big deal. But sometimes, especially like these old labs, get a bunch of lipomas, which are little benign fatty tumors. And a lot of times the owners are like, just remove the one in the armpit. And then the doctor might go, well, which one am I looking at? Which one am I, you know, and you're the one that took in the animal. You got to be like, oh, it's the one in the armpit. So when you're also taking the history, now I think everyone's really good. Every time I teach this class and I say, go over what's in a signalment, everybody can pretty much spit that out to me. But the other thing that we want to find out, let me go back a second, sorry, is any current or past illnesses. Have there been any issues with Fluffy in the past? Have any concerns about Fluffy? Are you giving Fluffy any medication currently? This is important, and I want to stress this because when you ask owners about medication, they usually are thinking veterinary medications. And they'll say, no, Fluffy's not taking anything. But then we find out they've been giving over-the-counter aspirin because he's a little old and his hips are a little creaky. Okay, that's a medication. And aspirin is huge because aspirin prevents clotting. If you're getting ready to do surgery on a dog that's been on aspirin for a week or more, that dog is going to bleed, bleed, bleed. A lot of times we will send that dog home if it's not an emergency, and we'll say, we'll come back in a week after the aspirin has been stopped. But a lot of times owners, it's always kind of embarrassing. I'll ask that question. The doctor will go in the room and he'll come out and say, oh yeah, that dog's been on aspirin. And then I kind of get a little mad because I'm like, she didn't tell me that. I asked her. So sometimes owners leave out, but you always want to say, are you giving anything, any medication, anything over the counter? You also want to make sure, has there been any drug interactions, any allergies? And whenever I ask this, they're like, well, yeah, he's allergic to grass. And I'm like, okay, not skin allergies. I mean, have you ever given him any medication? Any, you know, has he ever been to the clinic? You know, vaccine reactions, things like that. And then you always confirm that preventative care. This is everything you need to know what's in a signalment. Obviously, you know, age is going to be huge because, again, age is not a disease. I anesthetized a dog, believe it or not, had a brain tumor. The lady had proof this shepherd mix was 17 years old. 17. And it had a brain tumor. Brain tumor radiation is 16 radiation treatments. Runs about $6,000. This lady came from Kentucky. and we radiated this dog. We anesthetized a 17-year-old dog 16 times. That dog did better under anesthesia than some of my middle-aged dogs did for radiation. This dog was like a textbook. I was like, look at this beautiful monitor, look at these beautiful values. So a lot of people are afraid, and a lot of clients are like, I don't want to do a dental on my dog because he's old. I've seen a lot of very healthy old dogs. Now, we have to work them up appropriately and make sure, but there's a lot of times you're going to have, and older animals come in for dentals. And most dentals, you'll do sometimes 3 to 5 dentals a day in a practice. So dentals kind of become your bread and butter. And these are going to be your geriatric patients. And these are the ones that sometimes fall outside that window of normal. But I'm going to tell you, a lot of them do very well under anesthesia. So, it doesn't, just because they're older, doesn't mean it's going to be a train wreck. And the other thing is reproductive status. Males that are intact sometimes tend to have a little more, they have more testosterone. So they sometimes need a little more sedation because they might be, I don't want to say bully, but sometimes they've got a little bit more attitude, for lack of a better term. Females that are in heat, if you're doing something while they're in heat, they need more fluids during surgery. They tend to bleed more. Sometimes they need a little bit more sedation. So reproductive status can lead, to issues during surgery. Now, let me get into some species differences. Now, I'm going to mention a few things about large animal, but we are going to have large animal and anesthesia too. We do a whole section on the equine. I combined pigs and cows, and then we do a section on exotics. So I will get more in depth with these species later, but I will tell you, horses and cats are very sensitive to opioids. Opioids are like morphine. So if I ask you, what species do we use caution when we use opioids, you would tell me horses and cats. Cats are not really supposed to have the pure agonist opioids like morphine and hydromorphone. Cats get something called morphine mania. They almost act, there's a theory that horses and cats have more opioid receptors available. Okay, so when I give a drug, if a species has more receptors available, that drug is going to bind at a higher rate and cause a more profound effect. Now, opioids are great for pain, but the side effect of opioids that we have to be cautioned about is dysphoria. If I have a 10-pound cat that is dysphoric, and dysphoric means they're like howling and paddling, and they're kind of like, are you here? If I have a 10-pound dysphoric cat, I throw it in a blanket and hold it till it calms down. If I have a 1,500-pound horse that's dysphoric, I don't want to be anywhere near it. I don't want to be near a dysphoric thoroughbred. I don't want to be near a thoroughbred, first off. Second off, I don't want to be near a dysphoric thoroughbred. So in those species, there are other drugs that we can use. We can still give horses and cats pain medications. We're going to choose a different medication. Dosing is different. I will tell you, cows and horses, xylazine is a drug that we use. It's called an alpha-2. If I have a horse and a cow that weigh the same, the cow gets 1/10 of the dose of xylazine that a horse does, because cows are ultra sensitive to that drug. That's a species difference. Even though they weigh the same, they could be the same age and the same weight. They're different species. They react differently to the drug. So recovery in horses is an absolute nightmare. Horses don't like to lay down. When you have a horse, the minute they think they're awake, they try to stand up. And they get this crazy look in their eyes. They get nystagmus. And if a horse tries to stand and they have that nystagmus, they're going to flip and roll and they could potentially break a leg. So when I get into equine, there are specific things that we can do in recovery to make it safer. We weren't even allowed to be in recovery when I was at Purdue with horses because it's so dangerous. Even if we helped anesthetize the horse, we had to kind of watch from like a little window because they were like the liability of a horse waking up. They didn't want any students nearby getting hurt. I'm going to get into, large animals need to be ventilated more because of the weight on their lungs. They almost always go on a ventilator for anesthesia. Cats and ruminants make a lot of saliva, and exotics are a whole different ballgame. Okay, so we'll get into these deeper when we get into these topics. Now, for this section, I do want to talk about this a minute. Let me pull up. I sent you guys. Hopefully, can you guys see this chart? Hopefully you can. Okay, you can see it. Okay, good. I sent this to you. This was a PDF. And in the notes, it brings up a few things. But let me go through this chart because since I am focusing on dog and cats, these dogs, any of these breeds that come in are the ones I think about even before I take a history. If you have a brachycephalic, Bostons, Pugs, Frenchies are very popular, English Bulldogs, even like Pekingese, King Cavalier, even a boxer. Now, Bo, my boxer, he's got a fairly decently long snout, and he doesn't really snort. He doesn't really snore. He has this cute little snore. But some of these dogs, it's basically their airway. They've run into a wall, and everything is smushed, shortened. They tend to have something called brachycephalic airway syndrome. They are prone to airway obstruction. That can be during induction. That can definitely be during recovery. If you remember, the two most dangerous parts of anesthesia are induction and recovery. And so what do we look at? How do we treat them? Well, we don't excessively sedate them. I don't like whop them. I want them a little bit with it. So we tend to do lighter sedation. Alpha-2 agonists, these dogs I'll get into what alpha-2 agonists do, but they already have a high vagal tone. They're prone to bradycardia. And some of the alpha-2s cause vomiting. I really don't want a bulldog vomiting prior to surgery because when they vomit, they have a higher incidence of aspiration. So I always think in a bulldog, I really don't want them puking before anesthesia. That's going to just make my job harder. ACE promazine, we usually decrease or give half the dose. But the big things here is the appropriate sized E-tubes. Brachycephalics have small tracheas, okay, the windpipe. I'll give you an example. I anesthetized an 80-pound bulldog. He was 80, 85 pounds. Normal weight. He was not overweight. He was ginormous. If I had an 85-pound German Shepherd, an 85-pound German Shepherd would probably take a 12 or a 14 endotracheal tube. The 85-pound bulldog took a 7 endotracheal tube. That's half the size of the German Shepherd. Same body weight. Same body weight. Trachea was half the diameter. So when I go to intubate these dogs, I have several tubes I usually lay out. I teach you guys to put out 3 tubes. The one you think you're going to use, one bigger, one smaller, because you just have to estimate. When I have a bulldog, I might have 4 tubes there or 5, because I had a Frenchie once, and it was a smaller Frenchie, but decent. That dog took a size 5 endotracheal tube. I've gotten a 4.5 in a big cat before. So this dog was just a half size up from a cat that I intubated. Okay, so let's just give you an idea that their tracheas are small on top of having a long palate, okay? The big thing with these guys is recovery. When I go to wake up a bulldog, they have to be pretty much like coughing, chewing, standing up. You know, you're taught, and if those of you guys that have helped in a clinic, usually they swallow 3 times and we say pull the tube. In a bulldog, I want them sitting up, moving their head. And there's a big joke. I'll try to find the slide for you guys. But normally they have a picture of a bulldog sitting there, and he's like has an endotracheous tube sticking out of his mouth, and he's just like looking around. And the joke is he's never breathed this well in his life. So he's like, I'm not getting rid of the tube. This is great. I can breathe. So it kind of becomes a joke about that. But the big thing is long palate, prone to airway obstruction, and small tracheas is what I want you to know. Now, sight hounds. If you're not familiar with what a sight hound is, and hopefully you remember talking about with breeds, it's anything like the greyhounds, the whippets, Afghan hound, borzoi, Irish wolfhound. I even in my brain, I call collies long-haired sight hounds. A collie isn't technically in the sight hound category. They're technically a herding dog. But collies act a lot like sight hounds. The big thing with sight hounds is they have issues with drug metabolism. So they have an increased responsiveness to sedatives, especially acepromazine. So we usually decrease our ACE. They have delayed recoveries from propofol. We don't use barbiturates anymore, but when I talk about barbiturates, because they're usually on the board exam, barbiturates were contraindicated in greyhounds because they would sleep forever on a normal dose. So they have extended recoveries. They have very low body fat. They're usually very lean. I mean, tell me the last time you saw a fat greyhound. Very rarely have I seen an overweight greyhound. Exactly. I'm like thinking in my head, I'm like, I really don't think I've ever seen an overweight greyhound. And they're very lean, so they have a lot of muscle, but they have a very low body fat. If you guys remember in pharmacology, certain drugs are lipid soluble, okay? Certain drugs we bank on going to the fat. So some goes to the fat, some goes to the brain. If I have a dog that's lacking fat, more drug is available to the brain, if that makes sense. So when we have dogs that are lacking the fat component, which is typically sight hounds, we have to adjust the dose. I usually lower my doses in collies and greyhounds. And a nice little tip, which is funny but annoying, if you take a greyhound in for a surgery, the owners of greyhounds are usually, I'm sorry, maybe someone in here owns a greyhound. There are certain greyhound owners that are like, let me explain to you how to anesthetize a greyhound. And I just look at them like, okay, can you please tell me how to do my job? Not that I've anesthetized 5 million things already, but go ahead. So greyhound owners, now, actually, Haley, the blood-brain barrier does contribute to collies and their sensitivities to drugs. But literally, for ivermectin is the primary drug that you shouldn't give to collies because of the blood-brain barrier. Their sensitivity to drugs can also be because of the blood-brain barrier. Now, ivermectin we don't use, is not recommended to or sheepdogs. But one of them, Shetland sheepdogs, if that's what you're talking about, Michaela, because there's the Old English sheepdog and then there's Shetland sheepdogs, which are very different. Yes. Shetlands, which are Shelties, which are mini collies, I am cautious around them too, a little bit. But I'm just going to say collies in general tend to be one of those breeds. If you shave them down, they kind of have that sleek body about them too. Now, I've seen more overweight collies than I would a greyhound, but that's just an observation. When I've anesthetized collies, I've gone really low on my doses because remember, I can always give more. So I had this collie, I gave a quarter dose of the normal sedative level I would give to another dog. I quartered the dose. And that dog, it hit him like a ton of bricks. And I'm like, I'm really glad I quartered my dose, because had I given that dog the full dose, he would have been like out, out. A quarter dose was plenty. And I knew if I gave a quarter dose, I could always give more. So you tend to, there's some, you want to avoid barbiturates. They need warming. They are prone to hypothermia because their lack of body fat. And I will get into hyperthermia. They can get malignant hyperthermia, which is, it is often fatal. I lost a greyhound to this when I was at Purdue, and it was a rescue greyhound, and we were spaying it, and then it was supposed to go down and get a dental. It was rescued from a racing track in Florida. We kept greyhounds in the hospital at Purdue for blood donors. We had 4 that lived in the hospital. They would go home on the weekend with students. They had very nice runs, padding. After they did their time as blood donors, they were adopted out. So when we would bring them in, we would spay them, give them dentals, do their vaccines, blood donor. Well, this dog started getting very brick red during anesthesia, started getting a high CO2. And this was a long time ago when we used a drug called halothane, because I'm super old. So I was in the halothane era, and it could bring out hyperthermia. And we went to take this dog's temperature after the spay, and he was 107 degrees. And by the time we got him down to the dental and we were going to try to cool him, he went into cardiac arrest, because it is a genetic muscle condition. It wasn't because we had him on a heating pad. It wasn't because the anesthesia brings out this condition in certain pigs, greyhounds, people can get malignant hyperthermia. The drugs that we use now, isoflurane and sevoflurane, don't tend to cause that condition like halothane did. So it's not as prevalent, but it's there. So that's what hyperthermia means. Now, herding breeds, so your collies in here, I always treated collies like Siamese, but Shetland sheepdogs, border collies, this talks about that ABCB1 mutation, which is literally the leaky, that's a fancy way to say leaky blood-brain barrier, okay? This P-glycoline protein pump mutation, that is the leaky blood-brain barrier. So you can get drugs that accumulate in the spinal fluid. Normally, that area is protected and drugs don't reach a certain level. So we reduce our ACE and our sedative. We watch them when they're waking up from sedation. They can be excessively drowsy after normal sedation. So you watch them really closely. And then toy breeds. The toy breeds, not that we have an issue, they are prone to hypothermia because they're little. And I will tell you, temperature drops fastest the first 20 minutes of anesthesia. And a lot of times when you first anesthetize a dog, they're on a metal table, and then you roll them over and you shave them, and then you put wet prep on their belly, especially if you use alcohol. And then all of this can predispose them to hypothermia. And once they get cold, it's very hard to bring them back up to, it's much better to keep them warm right off the bat. If you can start by putting them on a heating pad in the prep room, baby socks on their paws, warm IV fluids, cover them with a towel. There's a picture in I used to teach Animal Tech 6, and I talk about hypothermia and surgery. And there's a picture of a Chihuahua wrapped in saran wrap, and only the leg for surgery is sticking out. You can wrap up these little guys in saran wrap. It helps retain body heat. Bubble wrap. Just get that press and seal. Get a roll of press and seal and wrap up the animal during surgery. But I'm going to tell you, you really want to keep them warm. It helps with recovery. So you want to try to use these warm blankets. And you want to try to watch also hypoglycemia. If you fast a Yorkie or a Chihuahua or a little Pomeranian, one of the first things we used to do when they came in was get a quick little glucose on them, or check a glucose on recovery, because they really need to eat. They may need sugar. dextrose in their fluids if they're too hypoglycemic. Now let me go to the flip side, giant breeds. When you work with the big guys, Newfoundlands, Pyrenees, St. Bernards, Great Danes, they have a very profound response to sedatives. Remember this, burn it into your brain. The bigger the animal, the slower the metabolism, okay? I'm going to tell you, if you have a dose of acepromazine or a dosage, the doctor says, I want this many mgs per kg. If you calculate it for a Newfoundland, that dose is going to be up here. We used to have a maximum acepromazine. We're like, I don't care how much the dog weighs, you're never going to go above 3 milligrams. Okay, so if you calculate 5 milligrams for that dog, you're only going to give 3 milligrams. So there are some sedatives, especially acepromazine. Acepromazine, I always use lower doses in my big guys because they have a more profound effect because they have a slower metabolism. And you can always give more. If I give it and then the dog looks at me like, what else you got? Then I'm like, all right, I'm going to give you some more. But some of these drugs you cannot take away. Some of our drugs are reversible. I will talk about those drugs when we do the drugs. But acepromazine is a drug you cannot take away. Once you give it, if you overdose them, you're stuck with the side effects of an overdose. So it's very important in these guys to lower your dosages. Now, Doberman pinchers, and I don't see as many Dobermans as I used to. I love Dobermans. You know, I'm kind of into my boxers right now, but I always said I was going to have Dobermans one day. Dobermans have I know Ashlyn and you and I are simpatico on this. We love our Dobies. They have a high incidence of dilated cardiomyopathy. It's genetic in Dobermans. There's a few breeds, Newfoundlands, Dobies, Irish Wolfhounds, boxers can get it as well. And so you have to screen them. Now, the other issue they have is von Willebrands. And I think you probably went over this in lab, but it's a clotting disorder. And if a person owns a Doberman, they should be educated on this. If they want to have their Doberman be spayed, 6-month-old Dobie comes in, we got to listen to its heart really well. And we're potentially going to do a clotting panel to make sure, or to check it to see if it has the von Willebrands factor. Because what's going to happen is they're just going to bleed and bleed and bleed during surgery. Especially anytime a Doberman came in for, oh, go ahead. Oh, did someone want to say something? Okay, if you're potentially going to spay, or especially do an orthopedic procedure, when you cut into the bone, it's very bloody. And you're going to want to make sure they don't carry the von Willebrands factor. There is a medication. It's kind of like a plasma transfusion, except what you're doing them is you're giving them the factor. And so what we'll do is we can do surgery on these Dobermans. We order this special, it's a precipitate. My brain is freezing right now, what it's called, but we can give them this infusion prior to surgery. And I will say, there is a note on here, NSAIDs potentially. Now, NSAIDs can interfere with clotting. Not in most normal patients, it doesn't cause an issue, but you'd have to screen that Doberman potentially. But you would want to use the COX-2, the selective NSAIDs. Your Rimadyl and your Duramax are going to be better for that. Now, boxers, of course, there is some theories out there. UK lineage. So there's what they call the European or English boxers, and then they have American boxers. American boxers are supposed to be the ones that have a little bit of the longer snout. If the boxer's a little more smushy faced, now that's if you're just looking at the boxer and you have no idea. Sometimes the owner will know from the breeder, these boxers are of the European lineage, or the English. Sometimes call them Euro boxers, or they call them English boxers. I believe Bo, nobody told me, just by looking at Bo, he looks like more of an American boxer. But I will tell you, they cardiomyopathy, you got to listen to their heart really good, check their pulses. They can get bradycardia and sometimes severe sedation from acepromazine. So some people will not use alpha 2s in boxers. They will sometimes give anticholinergics preemptively, like a pre-med. I don't normally pre-med everything with atropine. Usually I save atropine for if we need it. Some doctors will pre-med everything with atropine to try and prevent bradycardia. And some doctors will avoid ACE in boxers. I will say, when Bo got neutered, he woke up a little, like he started kind of, and he was paddling. The doctor, she's like, I want to give him a little ACE. And at first, I was working a whole shift. So I was like, if he sleeps, I'm working, it's fine, I'm not leaving. But what she did was she just basically washed the syringe with ACE. This is a little technique, this is a little tip. She drew up acepromazine in a syringe and she squirted it all back in the bottle. The syringe is kind of coated with ACE. Does that make sense? And then she drew up some saline and then we gave it. So the saline was this very pale yellow color. We call it a titch of ACE. It is not scientific. It is not a dosage. It is literally draw up ACE, squirt it back in the bottle, draw up saline, and you have a little bit of ACE. And I'm going to tell you, that pretty much knocked him out. He went to sleep. He slept for like the next 2 hours. He didn't thrash. It wasn't even a dose drawn up. She literally just went saline. And I've done that before, where I've washed a syringe with ACE, drawn up saline, and given it. And it was enough sedation. So I will tell you, my initial response was like, I don't know if I want you to, I can't get out of this screen. Anyway, I don't know if I would probably avoid it or do that technique. Wait, somebody's saying something. I lost you guys here. A German boxer, so German and UK, they're both the Euro boxers. So if you knew it was a German boxer, a European boxer, some people use those terms interchangeably. Those are the ones that are supposed to be more sensitive. The American boxers aren't. But the problem is, like I said, a lot of people get a boxer and they don't know. I even had to kind of look up Bo, like pictures, because I was like, is Bo an American? And the Americans have a little bit of the longer snout, which I prefer anyway, personally. So that's just a tip. Again, I've sent you this chart. I want you to be familiar. Yeah, the German boxer is more smushed. German and UK boxers have a more of the smushed space. The Americans tend to have a little bit of a longer snout. So that's kind of, there's other body things to look at, but most of the time people describe it based on the snout. Okay. So I think because it's about 11 and I can't get out of this screen to get back to the PowerPoint, I'll stop here. Does anyone have any questions about, I do just be familiar with a few of the things I talked about with species and with these breeds. And I will come back to it more. Okay. So what I'll do as soon as I'm done, I'll convert the video, I'll send it out, and I will just see you guys at the same time tomorrow. And as long as you typed here in the chat, you are good. I got a bunch of people that typed here. So I will just plan on seeing you guys tomorrow. All right. Have a good day. Oh, my boxer puppy that I'm getting, there weren't any left. He was the last one of the litter. He's in central Illinois. He's near Springfield. Yeah, so there was, I think there was 7 or 8 in the litter. And by the time I contacted him, I was on the phone with him, and
Guys.
he had 7 or 8. A female and a male were left. And while I was on the phone, he goes, "Well, I just sold the female." And I was like, okay. And I wanted the male anyway, so I wasn't like, "Oh, the female's gone." They looked almost identical. He's a black. He's got white here. He's got white on the tips of his paws. He's got a little white on his chest. Oh, do you hear me okay, Ashlyn?
I can hear you now.
Yeah, he's black and white, but he was the last male left.
My brother, he has a boxer. She's almost 11 though. So we've been looking for another one, but we cannot find them anywhere.
Right. You know, they